Kevin. How are you?
Good morning.
Good morning indeed. Sorry, by the way, if you can hear some background noise, there seems to be a lot of work going on just outside my apartment block. They're testing fire alarms, they're doing all sorts of buildings. It's a bit frustrating, but hopefully you won't be able to hear too much because of the earphones here.
It happens.
That's the downside of working from home sometimes, isn't it?
It is. Or an office. Offices can have people knocking at doors and you're on a presentation. So
This is
hopefully we're
true.
all clear.
Hopefully. Well, welcome everybody to this week's Event Insights. For anyone who hasn't been here before, my name is Chrissy. I'm head of content with Safe Events. And joining us today, we have Kevin Jones. Kevin, you're very welcome.
Awesome. Thank you very much for that wonderful introduction. I'm going to do a quick screen share. Hopefully our tech works. Chrissy's going to guide me through this.
Yeah,
And let me
absolutely.
know that my screen share is working.
It is indeed. And just while you're checking out those slides there, Kevin, to let everyone know, for anyone who doesn't already, Kevin is the head of Odyssey Medical. He's an executive director and managing partner. So they specialize in event medical, first aid, and health and safety for mass gathering events. And that's exactly what he's going to be running through with us today. So he's going to be talking about planning for medical care at mass gathering events. And as usual, this will be recorded and we'll be sending out the link to everyone on Friday. Kevin's presentation will probably be about 40 minutes, and then as usual, we'll hop over to the Q&A section on the chat box there, and we can fire a load of questions at him, which he's very excited about.
Excellent. That's a wonderful introduction, and I love a good Q&A. So thank you very much for first off, the invitation. Second of all, helping to moderate the chat and conversation. So love to see if folks want to do an intro of where they're calling in from. That's also welcome. Give this conversation some context and regency. One of the privileges of doing a presentation to an international audience is also trying to localize some of the information. So I may talk in a context of Canadian healthcare systems, and then it's about your ability to take this information and localize it, understanding what it means to you as an event planner, as a safety professional, maybe a medical professional. What does it mean in your local context? So bear with me. We'll get through some slides and some stories as we go through this. And again, welcome your Q&A in the chat, and Chrissy's going to help moderate that for me. So just my disclosures really quickly. So president and managing partner, Odyssey Medical. We're an event medical services provider primarily focused in the Canadian landscape. And then I'm also a board member of the Event Safety Alliance of Canada, which is a group of event professionals dedicated to progressing the event safety conversation within the Canadian context and working for advocacy both on the production and the governmental side of things to make events safer. Lofty goals, new organization, certainly supported by many of the other international organizations dedicated to event safety and the continuance of this conversation. I think looking at the international landscape, we have lots of opportunity to share stories and learn from each other. So a funny story. So this one time, we got asked to provide medical cover or medical services for a mud run. And if you've never or ever worked on a mud run, you know that there is a lot of things that can come at you very unexpectedly. Primarily and ironically, the amount and the volume of mud. So how do you prepare for these events that are inherently bringing you into an austere environment? And these austere environments create some challenges for the medical team, both in the treatment, the access, the transportation of patients. And then a very most basic thing is just getting the mud off them so you can find out what's going on. Taking some time to deeply and richly understand those environments has made us successful to understand how you provide the medical services overlay in a variety of environments, particularly when the environment itself is indicative. This particular event held in Alberta was in a very, very muddy area, and the mud actually was like, it's bentonite. It actually resembles more like a dinosaur poop. It's really, really, really slick, and it makes things a lot more difficult to operate on, particularly when you're going into a native environment that's already going to be muddy. The clients and the participants in this case want to create more mud because they want to be involved in that environment. And then Lastly, what happens when the environmental factors stranglehold you? So you've got weather that can create havoc at an events. And I'm assuming, based on the audience and attendance and maybe the listeners' post, is that we've all worked in events that are under austere or less than ideal conditions based on what we've planned. So the medical services needs to be able to adapt to those conditions by having the right equipment, the right personnel, and particularly, and I know this sounds a bit campy, but the right attitude to go into these environments and understand how you can adapt your services, your service model to be successful in an environment that's inherently feels closer to a battlefield than it does an event landscape in the traditional sense. What I hope you can take away from this session, the concept of risk match care, understanding and developing a care plan for your event, defining and understanding the level of care on site, integrating your public and private resources into your plan, space and equipment from the minor to the major, and then transfer of care of communication. I hope my slides are talking points, and I hope that there will be some engagement in the Q&A processes. If you see something that jumps at you that warrants further discussion, put it in the chat. Christy and I will take that chat up shortly, and we'll have conversations about your questions. And if those questions are things that we can share with the group in context, that's fantastic. If they're general sort of spiritual questions, please open the door and we'll have that conversation. So again, we will go through these ideas, and none of this is hard and fast or set in stone. This is all, again, needs to be interpreted and put onto your local context. If your local environment, depending on your local environment, where your events are happening, and then who is providing any form of government or municipal oversight. So who is looking at the events from a permitting and permissions perspective. We have to start with at least one definition. I don't know that it's part of the code of making a presentation, but defining a mass gathering for lots of regencies is also a challenge, right? What constitutes regular operations versus a mass gathering? The World Health Organization defines a mass gathering as a planned or spontaneous event where the number of people attending could strain the planning and response resources of the community or country hosting the event. So a couple of key words in there: planned. So a pre-planned mass gathering, which is something that is permitted, it has the necessary permissions, it has the necessary planning infrastructure, it has the necessary systems and supports to be able to operate that event in a safe context, i.e. you've received permission from the local council to operate the event, you have received inspections from the health authorities related to washroom sanitation, food services, and the planned ones are the opportunity to look at the medical services in advance. The other one is the spontaneous, and the spontaneous can be things like protests or spontaneous events based on a celebration of, let's say, a major league sports win, where the planning process isn't there. It's not present because there was no foreseeable actions in advance to say, oh, this event may or may not happen. If the team wins, this is going to be the expected reaction. And then how do we integrate and respond to those situations are a little bit different because there's not really that pre-planning process. Assumedly that in the area and the governance areas that you work in, if there is going to be a large gathering coming out of a stadium with the potential of maybe a win, somebody has looked at that and said, okay, what are the potentials? What are the potential risks here associated with this event and activity? And how are we as a governing body going to respond to that need? So I'm hoping that's one of the only definitions that we talk about today, but we'll kick it off. Why is this so important? With heightened understanding, the safety planning can be more effective. Outcomes, safer events. And that's the goal. The goal of any event promoter, service provider, medical, security, food services, crowd safety and stewarding is with heightened understanding. So the more that we understand about our event, going back to my original example of the mud run, we didn't know what we didn't know going into some of those events because they were new. They were first time into the Canadian marketplace. So we started to introduce these large scale mud and obstacle runs or obstacle course racing. And there wasn't a lot of data. There wasn't a lot of information about it. Most of our information would have come through pre-activities based on what was happening in other markets. So in our case, United States, they would have had those events and they were able to share some data. But in the infancy, we didn't know what to expect. So we had to go into a bit of an all hazards, all hands approach to understand. So with a better understanding as you grow, as you develop, and as we share data, we can also understand what's coming towards us. We've recognized at multiple levels through WADM, through the World Health Organization, through the local Event Safety Alliance type groups, is that there's definitely a lack of shared data when it comes to events, event safety, and particularly the subset of event safety, which is the provision of event medical services. So we just need to encourage people to share data, get that data out in the open so we can start having conversations about what to expect, and it'll ultimately make this industry a safer place to be. I lied. 2 definitions. So we have another one. Mass gathering medicine is a dynamic field that intersects the medical fields of emergency, pre-hospital, disaster, public health, and emergency management. The success is really multidisciplinary, and I emphasize that it's a team effort. You need all of those elements brought together under one team structure to be successful in a mass gathering medicine deployment. If I pull each of those subspecialties, obviously emergency medicine, right? This is going to be the backbone of your physician level care. Your pre-hospital, this is maybe your paramedic level services, your pre-hospital, or as we try to look at it, as out of hospital care. Sometimes the pre-definition of saying, well, every patient goes to a hospital in the context of a pre-hospital is really, well, we can treat these people out of hospital. And there's a fine difference in that. Disaster planning, these are the folks that spend time and energy looking at what happens if this happens. Public health, our public health partners, more proactive, the proactive support systems that exist particularly within the government realms, of having the overarching responsibility for responding to things like a pandemic or other things such as large-scale health issues, but they also have a focus on the mass gathering space. And then our colleagues at emergency management, so people charged with the responsibility at the governmental level to say, okay, what happens if something big goes off, if there's an act of aggression, an act of terror, how do we respond to it? It's a team effort, and we really need to approach it in that context, is looking at what is the opportunity, what's an interest from all of these different organizations to participate and catapult themselves into the conversation. So risk match care, it's a term that we've kind of coined up, and understanding that risk match care has to do with being able to predict the care and services based on the following. Part of it is the activity. What are people doing while they're here? Are they running? Are they cycling? Are they listening to music? Are they participating in a protest? So they're, their civil liberties. The environment, green field, urban environments, rural environments, austere environments, being in places that aren't historically being used. And we see a lot of revitalization of old spaces that people want to use as event spaces. So they want to go into warehouses and they want to go into abandoned spaces. And that creates a certain risk profile that needs to be considered. The crowd. And so if it's going to be a mass gathering and there's going to be a focal point of activity, the crowd, the audience, in the context of being a bit of a passive statement, less participatory maybe, and then the participant profile. Who's attending this concert? What's the demographic? What's the age? What's the socioeconomics? What is the past behaviors? Are they prone to aggression? Are they prone to being a harmonious crowd? Are they have a propensity to be an active movement? Are they moving? Are they a crowd that moves around? And how does that profile factor into the event medical services deployment? Location and distance. Where are you? How far to other things? If you are in a central urban environment and hospitals are proximal, are you in a rural environment where transport times and distances may be prolonged because of the length of time away from those sort of bricks and mortar care facilities? What's the local community? What is the local community's capacity? What is their interest? What are their friction points? Maybe they're maybe the local community isn't too keen about all of these people invading their space, coming into their park. How does that influence the care that would be accessible outside of the event precinct? So the landscape of the event is, where else can they go for care, alternative forms of care, people that are staying in the community for a duration. So they're there for the build and strike phases, So it's not just showing up on the day and understanding there might be a health impact on the health community. It has to do with how long are people in that community to participate in the event and how long are they staying post. So if you have an ultra distance endurance event that's going into a resort community, you may be looking at a situation where people are coming in for a couple of days beforehand to acclimatize. They're going to participate in the event, they're going to execute, and then they may stay for 2 to 3 days for recovery. They want to stay in the environment. They've turned it into a vacation, so to speak. So I think there's a real bumping effect that can happen when we understand the local community. And then what can you offer by way of past data points? Is there intelligence that's been brought to your attention that's available to you that allows you to analyze what's happened in the past? And past behaviors are they're predictors. They are used to predict what might happen. We use things like weather forecasts. What's the historical norms? So it's a data point that we're willing to look at. We just don't have necessarily the concrete evidence going past simply because we don't have the history, right? If this is a new event, if this is a first time event, you have to look at comparables. So you have to look at left and right of what's gone and up and down and do a 360 on that space to understand what might be needed, what might be predictable, and what might be forecastable. Types of care. At every level, your risk match care needs to understand, in fairness, needs to understand what is the level of service expectation on your site. Sometimes first aid is appropriate. First aid scope. You might be at the standard first aid. These are some terms I might throw around. Certified first responder, medical responder, EMTs, certainly in the American context of the word. At some level, these people should be able to provide basic care for people, and not typically introducing in most jurisdictions the concept of symptom relief, medication, and pain relief. They should be able to provide the airway, breathing, circulation, the sort of ABCs. Go back to your first aid training. Higher level care, scoped above the first aid level. And by the way, none of these terms are used to pigeonhole or be offensive to any one group. They're just terms in generality of a service level. I believe firmly that the delivery of event medical services is made about that. It's that team approach, and every certification has a role and they have a function and they serve part of the chain of custody and also the chain of survival. So your higher level care scoped above the first aid, this might be MD at the medical doctor level, usually with advanced interventions and symptom relief. So the ability to do advanced airway procedures, advanced cardiac procedures, symptom and pain management. So you're providing that out of hospital care. This would be very comparable to what somebody would be provided through in the initial golden hour of a case going into the hospital. If you're building out a higher level care model, you are looking at being able to recreate that golden hour within the precinct of the event. And emerging is harm reduction. This idea, we call this festival health in our context, providing services that look at how can we reduce people's harms to self. And it could be everything from sunscreen to sexual health to drug interactions to mental health interventions. I think we're seeing an increased trend in the need for those types of services where not every person's coming to the medical space with a physical ailment, a physical injury. They may be coming to you contextually with something that is a mental health and a mental health response. And I think it's a very important part of our overarching services that are being provided on site, that we're able to recognize the need for that type of service. And that type of service is becoming more and more expected. People are expecting to be able to find those certs. Final point on that is also understanding the exterior zones of the zone X's of your space, which is to understand that you may be bringing an event into a downtown core, and that downtown core space has general public health concerns and needs. How do those things interface with your event? And that's one of the areas we've found anyways, that harm reduction, those folks are very good at helping to identify issues, de-escalation, and then providing a care plan, which is an integral part of the services that we provide, is to make sure that somebody that comes to your event has a bad day, they get injured, that we can try to adopt a service recovery model by taking care of them. The same thing would stand true for somebody at an event coming to your medical tent that was not part of the event seeking assistance, what's your ethical and moral obligations to support and help those people? So there's other types of care. There's specialized rescue, so water rescue, fire rescue, working, treating and working people at heights in the pre-production space, and then the health and safety elements, which have a lot to do with taking care of workers who attend your events and are working to provide production supports. So understanding that, I think, is key. And identifying that at an early stage, and also respecting the fact that not every event needs a higher level care model, right? I've always felt that very good quality basic first aid for a lot of events is sufficient. It would stand up to being within the due diligence and standard of care of expectation. When you start introducing higher levels of activity, potentially higher levels of patient acuity, it stands to reason that the care needs to flow with that. It needs to match or escalate what it is. We look at different models to make sure that we have this dream model, and this was presented and created through a paper with Dr. Adam Lund as the helm of that planning process. And it was the dream model, and thinking about this is going to get a bit technical here, folks, so bear with me. You have the pre-event. Do we understand the knowable preconditions? If we know that there's going to be an event coming with that folks are going to be consuming substances, so do we understand that? And we were aware of that. I was listening to Natasha Beach did a really good presentation on the differences between sporting medicine and concert medicine, and I think that's a brilliant piece to understand that those medical programs could be considered to be drastically different. The needs of an endurance athlete versus the needs of a concert goer. So what are your inputs? Knowable preconditions, things you know about the audience before they come. The modifiers. What have we done in advance? Are there anything that we can do in the events by pre-educating, pre-warning, pre-talking about some of the behaviors maybe you're going to go into? We've just gone through a couple of significant weather events in our space, which was the Air Quality Health Index, so the AQHI in Canada, because of the outflow from the wildfires. So we had to do some mitigation strategies with many of our organizers to look at strategies to minimize the consequences of respiratory illness and injury pre-event by putting out messaging, looking at cancellations, looking at modifications, and that had something that had obviously a large influence of that was the medical program. During the event, like this is the operational phase. What's happening during the event? Are the conditions changing, and that therefore the patient presentation or the volume of presentation, is that changing? And is that going to be something that we would be able to adapt to on the fly? Are we able to adjust our program so that we're meeting the needs of our patients? And then the outputs, right? This is the post-event, right? What happened after the event? Do we understand richly how many people we sent to a care facility? How many people did we divert from a care facility? How many people spontaneously attended a healthcare facility post-event? They felt that they had left the event and now they're feeling ill. They attend, and now we have to understand the impact that has on the community, because it's simply not, oh, we shut the door, go home, and we don't consider the impacts on the health community after we leave the event. If we look at this at an even richer model, you can look at the inputs, the modifiers, the actuals, and the outputs. I don't think it's worth our time to go through each one of these, but there's a couple of these that are worth highlighting, right? And I think the population factors are really important, and our community-based services. What do we have in the community that can support the event? If you're in a rural state or area or province where there isn't the baseline healthcare, or that healthcare is under pressure, that healthcare system is unable to deal with the daily needs of the community, by superimposing another X amount of thousand people is not going to help that situation. In the modifiers is to understand legislation and policy. I think that's a key thrust that's underscored, because many times the Regency or the governing agencies don't have policies that support the medical services on site. They have fire code that tells you how many people you can have in a tent. What is the fire rating of that tent? They maybe go as far as understanding, you must have X amount of security personnel or stewards per space, and then bolster that with what we would call in our context a paid duty officer, an officer hired outside of the regular policing force to provide additional support. And so understanding the legislation, those legislative requirements, if they do, your on-site health services are built around that. They're built around if there's a requirement. And for example, through the Canadian landscape and extensive research, but stand to be corrected if it is out there, we've only found one Canadian jurisdiction that has a bylaw that actually provides a number. So what's the number of medical staff that you need to have per participant? There's recommendations out there, there's guidelines, but there's only one governing body that we're aware of that imposes using the bylaw function of what you need to have on site. So how many nurses, how many doctors? So that's a very interesting conundrum, particularly in the Canadian context, because we don't have any governance that says you must have. During the event, this is where your expertise as a event planner, event promoter, whatever the world is that you attach yourself into the event services, things like weather, time factors, ability to communicate, human factors, flow of attendance, rare events. This is really an interesting one, is how do event medical services providers on ground, be them private or government, how do they plan for the exceptions? How do they plan for the mass casualty? How do they plan for the mass opiate poisoning? How do they plan for the weather event that requires an evacuation? And in your medical space, you've now got patients that you now need to evacuate to a bricks and mortar care facility. And then looking at the outputs, right? And we'll talk a little bit about those metrics in a second, but the metrics are really important. So I think this is a really good graph. It's available online and it will be circulated post presentation. I think it's really worth considering the impact and the analysis that you do during your planning processes that ultimately influence your operation. We use a 7-step planning process, and of course, step 1 is that risk assessment. So a lot of times, if you've done the event before, you in fact start at your analysis phase. So look at what you've done in the past, and then come back through your planning cycle to refine what you've done in the past, and then to be able to operate with some sense of engagement and betterment. So in through these, understanding all of the different aspects and elements, I think it's a privilege to be able to look at those in advance and understand those, because if you go and put the spontaneous events through the same dream model, you come up with a lot less answers. So now you don't have a pre-event phase. You're simply having to respond to the call for service or a spontaneous event or the spontaneous growth event. There's been a number of times in history where ticketed events have gone well beyond their capacity. So now we've got a capacity at a greenfield site of 40,000, but maybe we have another 20,000 who didn't get the message that if you didn't have a ticket, you weren't going to get in. So how do we attend to the primary agency of our event? And then what about that zone X outside of the event precincts, but these people are putting pressure on the local community? How can we find ways to support those in the spontaneous context? And all of these modifiers, inputs and modifiers going through the different event profiles will cycle over the years. Events develop. So we get caught in a planning presumption. So it's like, oh, we've done this event for the last 15 years and this is how it's gone. Well, the Boston Marathon, they changed their planning model after an event of significance. So once that event of significance happened, then there needed to be some modifiers. They needed to look at different strategies and expectations based on a significant event. And the significance of that event has had long-running changes to their medical program. Their medical program has evolved drastically because of the Boston bombings. So every time we look at an event of significance that has an impact on the medical services, Harvest Festival, active aggression, vehicle-borne incidences or penetrations into the event site with the intention to cause harm, right? Weather events, every time, shootings at, Wonderland recently. There's just ways for us to look at the modifiers that help us to understand based on changes that are happening in the industry are, coming out of the post-pandemic phase of the world health populations is we still don't fully understand the impacts of, let's say, something like long COVID has on the community, has on the healthcare of individuals. So we need to fast forward through that data as much as we can to understand it as best we can. So just to really recap, you have your pre-event planning phases, You have your during event, your operational phases, and then your post event and your analysis and learning. And this last little part, and this is why I reposted this, is that reporting and publication, is scanning the universe for any documentation or information that's being shared in practicality. Australia, the UK, the US, they have lots of governing policy and guidance that talks about the planning process and how you plan for the services of the injured and ill on event. But the reality is, what do we do and where are we sharing the post-event information? What actually happened? Can we envision a day when there's a national database or registry of information where we can go in and look at a similar type of event, start looking at patient presentation rates? Wouldn't that be awesome? Understanding your local healthcare system. So the local healthcare system has a lot to do with what healthcare system are you governed by? Are you a social healthcare system? So it's free medicine for all patients. Is it a pay for service model? So you're going into an insurable state where people have different levels of insurance. And then how does that influence the care that you provide on site or the expectation? Imagine you're in a situation where for a period of time, for the attendees at a residential camping festival, you become the healthcare system. You're it. So people will come to you with general ailments that they brought to the event. And then they are going to go home with those ailments. And what care can we provide to them as a continuum when they arrive on site, as they stay with us, and then when they leave? So integrating your local healthcare system, I've used some generic terms simply because I wanted to give this an international context. Is your local healthcare system could start with your pre-hospital care system. So your ambulance system, how do we move somebody from site to a bricks and mortar facility? What system governs that? Is it a paid system or is it a social system? And it's a social system. You are working primarily with a government agency that is going to help, understand the needs to be able to move people from your site, your greenfield site or your temporary site, to a bricks and mortar facility. So what I've learned over the years is certainly early planning and engagement. Isn't that lovely? The benefit of time. Right? The privilege of time is to get those conversations going, understanding what is local governments. Maybe the utilization of private ambulances is not permitted by law, so therefore you need to use the government system. Maybe you're in a jurisdiction where that is allowable, where private companies can transfer people to bricks and mortar facilities. What are those bricks and mortar facilities, that, aka hospitals, urgent care clinics, and midpoints in between, everything in between, that you use to be able to create for people and relieve pressure from the traditional healthcare system? Maybe your healthcare system is world class and there's no waits, there's no waiting in line because there's many options, but it's under insurable services. So some people have the capacity to seek that and some people don't. And how do we make sure that the concept of event medical care is boundary free? People should be able to get care. I think it's within certain levels of due diligence. Whatever governs due diligence in your country is to understand that you probably have a duty of care. You probably have a duty and a responsibility to provide some basic life support care to a person who's bought a ticket to come to your event. Not a lawyer, but it's something worth investigating. Early planning and engagement, understanding local governance, understanding capacity and system capacity and surge. So what is the day-to-day system capacity if you're bringing 20,000 people into a remote area? What is the impact of putting 2 to 5 more patients into the healthcare system? That may seem to them like that's getting close to a surge. And then what is the true surge capacity? If you had a mass casualty event and you are in a temporary overwhelming patient load, a topple, so you have no capacity on site to treat any more patients, how can you start pushing patients into diffuse your patients amongst different care facilities? That may be a luxury based on your location. It may be a reality. You might be in a large downtown core setting where there's multiple hospitals. And how do you direct those patients to those facilities so you're not overwhelming one of those situations? I think of the analogy when we have free water stations on site, and you have like a whole bunch of people lined up at a free water station that are complaining about the length to get free water, and then you have multiple stations that are unused because of where they're placed. It would be nice if you were able to identify those and be able to move people to alternative places. I think of it the same way in the hospital system, is we can't put all the patients at one hospital. We need to diffuse those amongst the local community so that we're protecting the healthcare system for the community for which we're involved in. Communication, I mean, I think that's business 101, but communication, pre-event, during event, post-event reports. What are the data points that are measurable? If you can't measure it, what's the point of collecting it? And if you've collected it, what are you going to do with it, right? So we may trust a lot of things, but data doesn't lie. If we're able to talk about the number of people that came into our facility or attended our event, how many people were taken care of on site, how many people were transported off site, and therefore what are the treatment rates? And we use some acronyms, PPR, PPST, and they're all defined there for you by the patient presentation rate per thousand. How many people came to see you? Percentage of patients seen, and then they're transferred to the hospital, meaning we were the on-site medical services were an intermediary step. They were seen on site, and then they were transferred to a hospital. What was the actual true the ambulance transfer rate? And then how did people transfer rate per thousand of attendees over time? The other metrics that's really important to mention is the aversion rate. So how many people didn't we send to the hospital versus how many did? We, as the event medical services provider, we can't control the behavior of our attendees, right? For the most part, we respond to the needs. And simply put, is the aversion rate, the number of people that we did not send into the healthcare system, is a critical metrics. It's a critical metrics because it supports the services that we provide, one. Two, it allows us to talk in reality, because we hear lots of times when in the pre-planning phase, oh, those events are dangerous. They're going to hurt people. People are going to die. And the answer is having the data to support that actually can explain that having an event in your community, even if it feels like it's a large number, if you take that population over a regular community population, the number of transfers can actually be lower because there's more accessible care. And then with your integrated health, your health system is transfer of command and care, is understanding that crossover point. So where does the government start and where does the on-site services start? And if those services are integrated, that should be a seamless transition. The concern here is being able to understand the transfer of command. So if you got yourself into a situation on an event where the on-site services were at capacity and you needed to call in additional services from the government, who is going to take the agency, or the agency having jurisdiction? So who is the agency most responsible for the services provided, and where does that crossover point happen? Where does it go from it's the event medical services on site to now we're moving this towards the utilization or support systems that are created by the government? So the transfer of command and care on a per patient basis, it's very simple. Patient gets identified by our field team. They get transported to the medical space. They get treated for the ailment that's present. We still understand that patient needs to go to a care facility like bricks and mortar hospital. We have a transfer of care because we call in the responding ambulance crew. We do a patient transfer or handover. We put that patient on their equipment and off they go. Because if you believe it, right patient, right service, right time, right? Right patient, right service, right time. Having somebody at a music festival that has a long bone fracture, a leg fracture, there is not much you can do for that person. They need to be in a care facility that has x-ray capability and that has ability for casting, supporting, physiotherapy, and all the things that come along with that. So the transfer of care on a single patient is quite straightforward. The transfer of command from an on-site medical team to a government system that requires additional ambulances, additional resources, and they need to be able to integrate in the stream of the healthcare stream of the volume of incoming patients. So critical piece, understanding your presentation rates, how many people you might see per thousand, what is your aversion rate? So how many people did you divert from attending a hospital because the facility, the promoter, the organizer, the space decided to have advanced care on site? And then what was the transfer rate per thousand? Space, equipment, and supplies. And I'm going to go to about 42 minutes here, folks, so bear with me. Understanding your space requirements when I started out in this business was very challenging. So to intimately understand the space, the square footage that you need, has something to do with the level of care that you're expected to provide. And at what level of care, right? So bottom picture presents itself as being probably a higher acuity versus the upper picture is really about, this is more of a recovery space, a large scale space where you'll be monitoring people for a duration or a period of time. And I think it's important to understand that your services can scale. They can start at one level, grow to another level, and then scale down based on the needs of the population of the environment. Excuse me. What are the environmental conditions? right? Is it going to be hot? Is it going to be sunny? Is it going to be cold? So do you need to heat the space, cool the space? Sometimes you need to do the same thing in a 24-hour period, going from a cooling station to a warming station, depending on the type of year, the environment. And we all sit in blissful happiness that we're going to have an event day that's 21 degrees in Celsius. It's going to be like that for 3 days. The reality is, as climate change is happening, we see that, as we understand that that's not a reality. So we might see wilder swings in temperature and the needs for environmental conditioning to provide care for our present. There's no point in bringing a patient with a heat element into a space to provide them with care, but not understanding that is the same ambient temperature. We've lost one of our first cooling strategies. Surge capacity. How much capacity do you actually have in your space for a variety of patients? What would be the consequence of a 25% increase in the patient volume? What would it be that if you had to withhold a weather event and not evacuate, would you be able to control and utilize the environment to continue treating people? That's always an ongoing issue because people will get hurt during weather events, slips, trips, falls, those sorts of things. And then finally is privacy. Is in an austere environment, how do you create privacy? How do you create some veil of privacy? If you're having to do physical exams on people or advanced protocols, you need to be able to create sometimes instantaneous privacy around a patient because of where they are. Portable screens, those sorts of things are found to be very helpful. The space and equipment and supplies also has something to do with budget, right? There's a budgetary element to this to understand what you can have and what you can't have. And we all want everything, but unfortunately we have to consider that this is a mobile environment. So this has got a little bit of an element that it picks up and moves on to the next event or the next space. Folks, that's not the end of the session. That's just the end of the formal presentation. Thanks for attending. Find the fun. There's fun out there in the work that we do. I find it thoroughly engaging to do the work that we do, and I want us to all remember to find the fun. So, Chrissy, I think I'm turning it back over to you at this point for seeing if there's any conversation in the chat.
Yeah, absolutely. I think if I've just popped a message into the chat there to let people know to start thinking of their questions, pop something in. While people are thinking of that, I suppose one thing I was wondering, Kevin, is obviously you were saying that you use a lot of data to kind of prepare for things like this. So yes. What if it was a first-time event and you don't necessarily have all the data that you need?
Oh, welcome to my life, right? Welcome to any promoter's life is that we all want to go back to baseline. So we go back to baseline to understand what was done in the past. If you were taking over an event and as an event producer, what would you do? You'd go and look at the past plans. You'd look at ticket sales. You'd look at all of these different activities and pieces to be able to formulate a plan that says based on these things. So the reality is that you have to look at comparables. So you have to look left and right of you to say, hey, we've never done this marathon or this run or this concert before, but can we look to our friends in the space? And this is why data sharing is such a passion of mine, is to be able to call up the previous providers and or people that have seen this type of event and say, hey, you've got this artist, it's a concert, they're going to draw a certain type of profile. Can you help me understand, is this a moving crowd? Is this a stationary crowd? Is this a rough crowd? Is this a moshing crowd? Is this a lawn chair crowd? So really understanding that is about surveillance, right? And the continued surveillance of our market to understand what's going on. I don't think we've got it synergized. I think there's a lot of regional issues there. I think there's also from the promoter side, there seems to be this fear. I don't want to talk about the bad things that happen at my event, right? And if we look at research, what limited research there are, we know how to declassify information, right? Bring this information down to a point where it's de-identifiable. So we can talk about the research papers that have been done, and there's a few of them out there. There's not as many as other spaces, but looking for that data from research. And then final point is being able to encourage our clients, promoters, and event organizers to be willing to share the data. So somebody could call and say, hey, you did a marathon with 30,000 people. What did you see? You did a triathlon with 2,000 people. What did you see? You did a concert. What did you see? Right?
Yeah, that makes sense. Especially when you talk about going through, looking at, say, for any music events, looking at the different kind of crowds you have. Like I remember, was it Woodstock 99 they had that documentary about? And
Yeah.
they had basically a lineup that was set for disaster because obviously the crowd is just going to get more and more rowdy. But the
Yep.
event organizers obviously didn't really take that into consideration, did they?
No. And I think that's the part is understanding your audience profile before they're upon you. Once they're upon you, it's very, very, very hard to understand what they're looking at and what we're going to present themselves for. Warren asked a really interesting question. Do you have intelligence gathering programs looking for illicit substances? So when somebody comes to your site and maybe you treat them, are you able to look at the causation? Are you able to get to the reason for this level of intoxication? Warren, it's such a brilliant question. It's a hard one to answer simply because a lot of it's anecdotal. Can you trust the evidence that is provided with you on site? So if somebody comes in and said, oh, I think I just did X, right? And the answer is okay. And then you look through the presentation and you think, well, this actually isn't presenting like that. So somebody says, oh, I just had everyone, when you ask the universe, like, so what have you been drinking today? I've only had 2 beers, right? The answer is always 2 beers. It's never 2 beers and some cocaine. It's 2 beers. It's always 2 beers. So we always call it the 2 beer factor. So getting to the baseline information, Warren, has a lot to do with your post-event reporting, your post-event ability to review your charting and understand what you could put the classification. So illicit substance use, alcohol use, trauma, musculoskeletal, crowd-related, behavioral issues. So how do you put those into the classifications? And then looking down those informations to say, well, how many patients should I need to be prepared to sedate? So let's say we have to use some form of chemical sedation on a patient. Well, how many preparations should you have? And Warren, when you find the answer to that question, let me know, because I think it's still the X factor of understanding. But post-event data review, being slightly over-prepared. So if you anticipate you anticipate and know that 3 to 5 sedations has been the typical operation, and then how quickly on the medication supplies perspective can you get resupplied? So what relations do you have if you call up and say, we've reasonably been prepared for 6 of these procedures. We're now seeing an increased number of those procedures. How quickly can your medical system resupply you for the product and or the personnel? Suturing is a really simple example. We go to an event, we're prepared to do a dozen sets of sutures of the different varieties. And let's say we get to an event and there's a particular ground condition that causes people to get lacerations, cuts on their feet or whatever. So now we have to increase the number of sutures that we're doing, but there's a limit to what we can be prepared for. So both on the illicit side, people keep consuming drugs or overconsumption of drugs and alcohol, and then on the other side of it is ground conditions, traumas, and things that we hadn't anticipated seeing. So good question.
We have one here as well on the Q&A section from Nathaniel Kennedy. He's asking, which Canadian jurisdiction has a bylaw about medical care at events?
Oh, Nathaniel's a fellow Canadian, so he's that's a great question. It is Edmonton, actually. So the Edmonton jurisdiction, and I can happily share that with everybody post conversation. So due to a spike of incidences in the Edmonton jurisdiction, particularly related to raves or electronic dance music events, they came up with a bylaw, and their bylaw is supportive of being able to mandate the number of medical services provider at what level and type based on a bylaw. And they did that because there was a spike of incidences in the community. And it was a proactive approach. And the proactive approach was if we disallow this type of activity, it will go underground. And if it goes underground, statistically, it becomes more dangerous. So now the oversight is gone. The ability for people to provide governmental oversight has disappeared because now these events have gone renegade. So they're now all underground. We don't know where they're happening. We don't know when they're happening. And then people are having to work alongside the reaction, saying, oh my gosh, there's a pop-up rave that's happening in an abandoned warehouse. Now the public system is strained because without any pre-advanced warning or preparation, we now have to respond to any calls for service at that location. Imagine the day where you have a rave that pops up in your community with 2,000 people attending, and now we start having a rash of overdoses because people are there and there's something on site that's causing this condition to be exacerbated. So really great question, Nathaniel. I'll certainly pop you that link.
And then you might see here, we have another one from KT. How much data sharing is there currently in terms of trends, common injuries, etc.? Or are providers very insular, as they seem to be in most other aspects of the events industry?
Same. It's very insular, and we have the complexity of patient and privacy. So on a layer of security incidences, de-identified security incidences, so you're at a stadium sport event, and you know that you're going to have an injection rate of X based on history, and then you have medical instances of Y. Getting past the number is very difficult because of the perception of patient privacy. So organizers are very leery to share that information because they feel like it draws negative attention to their event, right? It doesn't support it. When in reality, if we put it on the table and have conversations, we can actually defend, right? And I think the position of defense is to say, people say, oh, these events are dangerous. And the answer is, well, look at them over time. If you look at these types of events over time, the injury and illness rate are comparable to other events that you welcome with open arms. So I think of the difference between a sporting event, the perception of a sporting event, let's say a world-class sporting event coming to your community versus a concert, right? There's going to be a perception that the concert is more dangerous than the sporting event, right? Because there's just more activity, there's more opportunity, and then the sporting event. But if you look at that numerically over time, it's not necessarily true. So I think there is a lack of data sharing. I will happily share through the Event Insights folks, events team, is that we can share some of the research that's out there. There is some research out there. It's just in comparison to other things, it's very, very shallow. Patient privacy, concerns towards negative attention to the event. People think, oh, this is going to draw negative attention, so why would I want to share it? And then the whole concept of privacy. Great question.
Well, that seems to be everything we have. If anyone has any other questions, you want to pop them in now before we let Kevin go. But in the meantime, I suppose, Kevin, that was really, really interesting. Thank you so much for taking the time to go through all that with us and to take the questions that we did have.
Love it. As a follow-up, anyone that's interested in following up the dialogue, always willing to engage, have conversations. Open invitation to come to Canada, of course, to see us, to understand the context of what we do. We're a large geographical country with a smallish population based on our land mass. So acknowledging the fact that we do have some key events that happen in this market, and that's growing. So love to reach out to colleagues through LinkedIn or email or just conversation. Love to talk about it.
Fantastic. We did just get one more in here, Kevin.
Oh, yeah.
Rick Larkin in the US. He's asking, is there a reference for the article you shared?
Yeah, Rick, we will, if you wanted to go one-to-one with me with your contact information, I'll send that out to you. Not a problem.
Fantastic. Okay, well, thank you so much, Kevin, and thanks everyone for joining us today. As I said, we will have this recording live on our YouTube on Friday afternoon. If anyone does think of any more questions in the meantime that they want to maybe go through with Kevin, feel free to either contact him directly or pass it on through myself, and I'll be able to get an answer for you.
Would it be okay? Is it okay for me just to pop my email address in the chat?
Yeah, 100%.
If they want to reach out?
Pop it in there. So yeah, if anyone wants to take down Kevin's
slide.
email address here, he's going to pop it in.
Make sure I spell it right.
Might come in handy.
Yeah, I welcome any reach outs, and I believe that we can pull down the proprietary nature of this information by having one-to-one conversations. And for me, the bidirectional willingness to share information, to say, hey, let's have a conversation. Let me help you understand, and then you can help me understand. And I think that's really important. So.
Yeah, exactly. Like as we were saying earlier, that data sharing to get more and more is obviously just going to help people and help keep more events safer.
Yeah. Well, in all things we trust, but data is the important part, right? Because it validates.
100%.
Excellent.
Okay. Well, thank you very much. All right. We will see you guys again very shortly.
Take care.
Bye now.